All right, folks. Well, welcome to the Bouncebacks Critical Care Book Club number 20. This is the 20th chapter, and this ends our section here, which is nice. We have A, B, C, D. This is the end of the D section, and we'll start our next section on Monday, April 1st. So hope to see folks there. I want to introduce our fine group of panelists here, and I'll just do it in alphabetical order. So we have Matt DeLaney, a friend of mine that we have worked together for many years, emergency medicine at the University of Alabama. And maybe it won't be too un-PC to say, good thing you're practicing emergency medicine and not being a fertility specialist there, Matt. Just saying.
Yes, correct.
No comment, right? Okay,
No,
all good.
no official comment.
All right, Cody Horn and I work together at Adena Medical Center, and Cody is a board-certified infectious disease specialist, and we have all seen him here before. So again, Cody, thank you so much for taking the time to do this. And Sean Nordt, a not only voice we know and love, but a face we know and love, both emergency medicine and toxicology, and a pharmacist. So having your expertise here, Sean, is fantastic. And then last but certainly not least, Evan Price, who is a senior internal medicine resident with me at Adena, and he has, congratulations, been accepted in a pulmonary critical care fellowship starting this coming year. So fantastic. So really exciting stuff. And no coincidence, Evan, that you're going into pulmonary critical care and you're on the Bouncebacks Critical Care Book Club. So thanks you guys for being here doing this. Also, of course, thanks everyone for taking your time tonight, and we hope we will be true to the hour of time that you have given us. So I'm going to put the main slide set on here, and I would tell you, as always, we have absolutely nothing to disclose, and I'll keep this up here for a minute. We have an hour of free CME for everyone that's here, and I'm going to flash a bigger QR code here next, so we'll just give this a second to sink in. And if you shine your phones on that, you'll be able to get your hour of CME. So thank you so much, not at our panelists, but folks who have joined. And I want to tell you that the case today is not just a bounce back case, but it's a bounce back case. So we'll see how that plays out in just a few minutes. We're going to really spend a very brief amount of time on the initial visit and then come more in depth into the return visit and focus, as we oftentimes do, on the critical care aspects of the return visit. And that's how this book, the fourth book in the series, differentiates itself from the first three books where we focus on that initial visit. And this one really focuses on those return visits. So this is a chapter 20, it's a 35-year-old man. He has diabetes and he has low back pain, and he has a history of intravenous drug use. So it's a patient that we see a lot. And still, all comers, if you're putting $5 down, most of these patients with low back pain are still going to have a lumbosacral sprain. But obviously, this really bumps up the risk as far as any significant risk for infectious type of things. And you might have got that why we have Cody Horn and as well as Sean Nordt on for some of these sort of things. So this is his initial ED visit. We're going to spend just pretty brief amount of time talking about this visit, and I'm going to ask Evan to go into some of the differential in just a second. But I'll just read you briefly the HPI, 35-year-old diabetic man, lower thoracic back pain. It's gotten progressively worse. Started an hour ago, constant first episode. Lumbosacral spine, lower thoracic, severe aching without radiation, worse with movement, no mechanism, and denies numbness, weakness, incontinence of bowel or bladder. So on the surface of it, this actually looks pretty good, right? Like we got a pretty good amount of information. But what I like to think about is this front door, back door approach that I sometimes use, and sometimes I'll say to the residents in the ED is like, okay, the patient bounces back tomorrow. They're, room temperature and horizontal. What do we miss, right? And that phrase that I'll sometimes use also, broken record alert, so sorry about that. But if it's not in the differential, it won't be in the diagnosis, right? So we're going to see as we go through that differential with Evan in just a second here that some of the things that are really important things weren't really even considered, it seems like, based on this history. But, all good for now, right? And we're all obviously looking back at this case in retrospect. The back exam did have paraspinal tenderness. Here's the next part, lumbar and thoracic x-rays. We're going to go into getting x-rays on non-traumatic back pain in just a second here. This is curious an MRI scan was done. And so maybe it's done for a certain reason, but we'll see that in just a few minutes here. And we'll see also how they discussed that. They actually said that there was a T7/8 disc herniation. And so they're going to have them follow up with a spine surgeon. So why don't we start with our first question, just directed to Evan. And Evan, if you could just go through a differential of some of the more serious causes of back pain in the ED, and then we'll sort of go back in our history and see which ones of those were further explored for.
Yeah, sure. I think some of the more serious concerns are like any sort of aortic or thoracic aneurysm. You could have a deep space infection, epidural abscess. You could also have osteomyelitis or even a malignancy. But and then the more benign ones, I like to think anatomically, going from is it a cellulitis? Is it something like a herpes zoster on the skin? Going to that lumbosacral strain, and then you can think about things in the chest or anatomically located. So pancreatitis, a renal calculi, pneumonia, PE maybe causing a large lung infarct. And then I always think of ACS just because you never know how it's going to present.
And I love you say the ACS because, I mean, it's really the thorax, right? And in the same way that you can get maybe shoulder pain with ACS or epigastric pain, you certainly can present as back pain. And actually, we had one of our cases in this book also that I think it was very early in the book, and it was a really tragic case, right? Because the patient presented with back pain, and it was not adequately explored. But why don't we just take a brief look at this and sort of think of some mechanical things like maybe some sort of spinal epidural abscess or osteomyelitis. We're thinking of other more vascular things like acute coronary syndrome or, PE, AAA, which would be unlikely in this age, but, putting it on there, pancreatitis even. And going back to this history, it's sort of curious to me that there's no question about fever. There's not really a question as to exertional discomfort or pleuritic discomfort. To me, it feels like those things weren't incredibly suspected. And when you think of a patient who has pretty significant tachycardia with a heart rate of 119, well, it's certainly something like a PE would be one consideration, or even a pneumothorax with that, right? So let me be just a little judgy here, and I apologize to all folks, and feel free to judge me also. But Matt DeLaney, and feel free to disagree with me also. But like, I'm just sort of wondering, like, starting with a lumbar and thoracic X-ray in a patient with non-traumatic back pain, are we just sort of hoping to get lucky here? Because if those are negative, it's not helpful, and if they're positive, it seems like we're going to do some further imaging anyway.
Yeah, I don't want to be overly critical. I don't understand the role that that would play in this case. Sometimes you'll talk about the therapeutic X-ray for the patient that's, gosh, I need somebody to look. We all know that that's not a diagnostically helpful data point. So, no, I agree, Mike. I don't follow the logic here. If I'm worried, I'm going to go for a better test than just plain films.
Yeah, they taught us. I remember at OSU when I was a student, they're like, that quote from the bank robber Willie Sutton, and it was like they asked him why he robbed banks. So it turns out, and the beloved branch point, they actually didn't ask him that, but it was attributed to him. So why do you rob banks? He says that's where the money is, right? So if you're really thinking of something like a spinal epidural abscess, you're going to go ahead and do this MRI scan. So Sean, you have over 2 decades, I won't say exactly how many decades you have actually, but of experience caring for emergency medicine patients, right? And our chart should tell a story, right? Do you feel like you really get the whole story? It seems like there's this huge workup for maybe what was the lumbosacral type of pain, but then there wasn't really a discussion as to why some of those bad things weren't going on. They sort of anchored onto these findings on the MRI scan, which we all know that test is very sensitive, but not very specific.
Yeah, there's a disconnect, and it's always easy sitting here, knowing that shit went wrong, for lack of a better word, right? But it doesn't make any sense. Like this is, so I kept reading because I printed it out and I've read it a couple of times, and either they were really busy and wanted to get their chart done, or they did their chart a week later, knew they got admitted and said, hey, they got admitted. I don't really need to flesh this out. But it really doesn't make sense to me. I mean, I don't want to focus too much on the vital signs, but he's febrile too, in my opinion, because was his mouth half open and stuff, right? And maybe they were fishing for, I don't know what. Or maybe when they got the MR, they said, you're not getting it without at least getting a plain film. But I wouldn't be able to get an MR. So there must have been something. He must have had like the IVDU history or something to push him, because it doesn't flow, right? The story doesn't make sense.
And I like to think of my chart as an argument, right? And sort of like a does the gloves fit type of moment, right? Like my chart is an argument for why I think that the diagnosis I made is actually the diagnosis, right? And why I think some of those other things aren't in the diagnosis. And it seems like the evaluation was a lot more thorough than the patient's history, certainly. And so some of those things that Evan talked about, maybe the ACS or even PE or whatever, right? Well, they weren't really even gathered. That data wasn't even gathered in the HPI to know enough even whether to do any further testing. I mean, they went for an MR of the back, and I get it, right? The patient had back pain. On the other hand, what was going on anterior in the chest? Were there some other risks for that? And the patient was diabetic, and certainly those patients can't present atypically. But we said we aren't going to really focus too much on that initial visit, and it's true that we aren't. So let me just go through bounce back visit 1, bounce back visit 2, and then what we're going to do is we're going to get a lot more specific when we get to bounce back visit 3, which is where that sort of fun type of stuff sort of starts as far as some of the critical care aspects. And just in case you are concerned that I have left out Cody, I will tell you this: Cody Horn, he is a confident guy. He is self-assured. He's really into muscle cars, and not that you need to know that. You will hear a lot of his expertise soon. Just not in this first segment. So I have not forgotten you, Cody, but thanks for hanging in there. All right. So patient comes back. I'm just going to very briefly summarize this. And he is there 4 days later. At this point, he does have fevers and chills. It's documented history of IV drug use. His heart rate is similar, a little bit higher, 123. And he has a CT angiogram of the chest, diagnosed with septic pulmonary emboli and sepsis. So, was that going on 4 days previous when there was some thoracic back pain with palpation? Maybe, maybe not. I mean, if you put $5 down in crystal ball, probably it was, right? So the patient is admitted and he gets, of course, IV antibiotics and then is discharged home. So this is on the 2nd, this is on the 12th of February. He comes back again now on the 18th, so 6 days later. And at this point, he's sort of diagnosed with a back strain. It certainly looks like they have further evaluated what was done earlier, and I'm not putting any criticism on this visit. I'm just sort of mentioning it because it's there. Very briefly, bounce back patients are high-risk patients when they come back. We certainly want to do things. I made a bit of a top 10 list. I'm not going to go through all those. If anyone even feels it would be helpful, take a screenshot of it. But the main things are just to make sure that we don't fall prey to diagnosis momentum, and we don't want to just go on that previous diagnosis that was made. And it's sort of like in Indiana Jones: The Last Crusade, when the German woman says to Harrison Ford, don't trust anyone, and then later she confirms why she told him that, because she was one not to be trusted. But never trust anyone, even if it's a person who you really respect, who saw the patient previously, because in all fairness, maybe their symptoms changed, maybe they progressed, maybe they presented atypically initially. So getting that additional information can oftentimes be quite helpful when a patient bounces back. So we're not here to talk about that. We're here to talk about visit number 4, which is the 3rd bounce back visit. This is one that we're really going to focus on. So let me just sort of go into this a little bit more here, and then we're going to go through our different decision points on this visit. So the patient comes in beginning of March. And interestingly, they did go through the differential from previous. And now this patient has all of our favorite complaint. I don't even have to ask about that, but vertiginous dizziness. And, you think you got, first of all, a patient with a lot of risk, who's young, but now has vertiginous dizziness. So we're going to really focus in on that as far as this evaluation. They documented the bloodstream infection, a PICC line, which we're going to go into a little bit more as far as any risk of PICC lines in patients who are IV drug users. And you look now, his heart rate seems to just be getting a little higher each time. Now it's 131. He is not hypotensive. Certainly appears anxious, and they did look at the PICC line, and it looked normal to them. So let's start off here with you, Matt, and just sort of starting off from scratch here. I mean, his presenting complaint is dizziness, so we could say it's vertigo. Whether the patient's able to differentiate vertigo from lightheadedness, hard to say. But let's just sort of go with dizziness in a patient with this history. Where are you going as far as your differential? And the second part would be, how concerned are you and how in depth are you going to try to work this guy up?
Man, I hate dizziness in all patient populations. I hate this more because the problem is, like you said, Mike, this could be the common causes of dizziness we see in all comers in the ED. The problem is, if we were to look at the literature, about 20% of patients who have endocarditis they'll throw clots to their brain. And the challenge to me is that I may know if you use IV drugs, I may not know if you have endocarditis. And so now we're looking at all these people that we all see, no matter where you work, that use IV drugs. They've got this risk factor for endocarditis. And if they have that, they got a huge risk factor for throwing something to their brain. So it's same, but different to me. I just identify if you use needles, the chance that you have something bad in your head causing dizziness goes way up. That I think the real friction point for me is, what do I do for these patients? I'm not going to send everybody who's used fentanyl for an MRI. We just can't do that. And so when I see this patient now, I just get increasingly nervous. I still think common things are common, but I am always uneasy in just the vague dizziness, particularly in a patient who's got a history of using needles.
Well, it's sort of a curious thing, right? Because when you think of a patient maybe with constant vertigo, where we're thinking of some sort of posterior circulation stroke, right? Well, a non-contrast brain CT is not going to help you at all because it doesn't adequately envision the posterior circulation, cerebellum, brainstem, et cetera, right? On the other hand, a patient with history of IV drug use, I mean, there could be multiple abscesses throughout the brain. So you'd be probably a greater chance of finding something with that CT. But then when you bump it up to the MRI, it's a really big commitment that you're making, not only with resources, but also the amount of time that the patient is there. So, Sean, you know, patients that are IV drug users, obviously, there's a lot of different sites, potential sites of infection with them. Bacterial endocarditis is certainly one of the biggest ones. I mean, probably lay people know about that also. But what are some other things, as far as in that same vein of it's not in the differential, it won't be in the diagnosis? What are some other places that we'd consider, that we should consider in patients that are IV drug users as far as other sites of infection?
So Mike, thanks. Let me just start with one because I want people to save a life out here. It doesn't probably go to this patient, but people say IVDU, and what they mean is parenteral. So that can be skin popping. Any skin popper is at risk for botulism, wound botulism, and they usually present the third ED visit and get quickly intubated because no one has done a documented, well neurologic exam. Anybody who says IVDU, first of all, find out if it's skin popping, which is subcutaneous, and always document, particularly cranial nerves, but a well documented, which we do not have here. So I just want to say that because you will save a life, I promise you, by doing that, because botulism, we can prevent it getting worse if we identify it. So, of course, I also do addiction, Mike, as you know. So they can shoot anywhere, right? So they call what's called a pocket shot, which is usually in the EJ, but you can cause a pneumothorax, shoot between the toes, under the testicles, right, in the taint, all different areas. So you really have to do a full body exam. It's great to have you. Hey, Cody, I'd like to talk to you sometime. When I was actually at Bellevue, when I was in pharmacy school, we had this really weird, I can't remember what bug it was, but somebody who liked to lick their needles, right? So it was this weird saliva-based endocarditis, right, that wasn't working on the drugs that we were thinking of, the typical like staph and strep virus and all that kind of stuff. So I remember working with the infectious disease team. I was doing ID at the time with the team, and so that's just very interesting. So of course you heard it before: cellulitis, right, abscesses, things like that. Endocarditis, spinal epidural abscess. That is one that I will argue very often with my spine surgeons, because they said, well, they're neuro intact. Well, yeah, that's what I'm trying to prevent, because once they're not neurointact, they don't get better, right? So the ones that I've seen are just like this, right? So tachycardia, maybe this intermittent fever, and I'd love to hear what Cody is, but that's what I've seen with spondyloepidural epidural abscess. And so yeah, you have to have a high index of suspicion. Peter Rosen used to always say, like, that's everything. That's like everything we do, right? So I think that this back pain in retrospect was referred pain, right? It's very easy to sit here. But it just seems like, Mike, what you said, every time I get a first time bounce back, it's like, what did the other colleague, they didn't do a bad workup, but what didn't they do that I can do? And there are just so many infections you can think about with these patients, right? They can even, let's say this is heroin assuming, and it says former, so I don't know what former means. How long is long? If they have the PICC line, are they starting to use because they have nice access? But they can just even nod off and aspirate, right? So you could have an aspiration pneumonitis subsequent with pneumonia. But I think with these patients, common things presenting most commonly, look for your abscesses, look at these things, even weird things. If they are these ones who shoot in their neck, like a rare Lemire syndrome, which is usually from like the oropharynx. But I'm a toxicologist, so I've seen a lot of weird stuff. So I don't want people to be freaked out by the things that we've seen, but you can see a lot of things. And of course, you have the list there, right? So pulmonary meningitis, SEA, HIV, right? AIDS. I would have sent, at least on the second visit, probably a CD4 count and then send a screening HIV test. Because again, am I dealing with somebody who's got a normal immunocompetence or not? And with that, I will hand it over to the true expert, Dr. Horn, when it comes to infectious diseases.
So two things, Sean, that you said that really, really made my ears perk up is that thought of like undressing the patient and that sort of also across the room neuro exam. I mean, look, I just did a neuro exam on you, Sean. I'm guessing you're alert Nordt ×3, but I haven't really done a neuro exam that I expect for a family member, right? And that same way, you'd see the skin of their face, the skin of their arms. That might be great for billing, but undressing the patient, looking for areas of skin popping or abscesses. I mean, I've had patients with, abscesses from skin popping who swear up and down they've never used IV drugs once, and maybe they're in denial, maybe they're trying to lie, maybe there's a family member there. It's just sort of hard to say about that. And in addition, when you say, do you use IV drugs? That's the present tense. And if they say they haven't used in a long time, well, 48 hours for a person who's withdrawing from IV drugs is an eternity. So I have expanded that question that I ask, do you or have you ever experimented with? It seems like it sort of gives them sort of permission to do that. So Cody, I'm going to actually bring you on here now, and I hope you're still with us here. Yeah,
I'm here. I'm not locked
in. We got a question from Josh Russell in the chat. But then also, I just wanted to have you sort of go into this whole like SIRS versus sepsis and sort of where we're at with this guy here. And I'm just going to put his story back up on the board here so folks can take another quick peek at it here while we're talking. So Cody, take it away.
Yeah, so I like to say that the sepsis is usually just more of a building term. I like to split in sick and not sick, and this guy's certainly sick. I generally say I have an area of folliculitis and I run up a flight of stairs. I'm going to meet sepsis criteria because you're going to see a dot on my arm and I'm grossly out of shape. So I'm packing away and I'm tachypneic. So I meet sepsis criteria. I might not be sick though. This guy's definitely sick. I mean, he's got the tachycardia. He looks very anxious. He's getting worse and worse. And this is many time back to the ER. So he's definitely sick. His only SIRS really is, he's got tachycardia. We don't have a white count. We don't have a bandemia here. But it sounds like this guy is pretty darn sick.
So what do you think, Cody, as far as at least in the door before any tests come back, what do you think about starting this guy on?
I usually cover for about 48 hours for the blood culture to come back. These people, like I said, mentioned, Sean mentioned the lick and stick, where they lick the needle, stick in the arm, and yeah, you get some funky bacteria there. I usually ask what you inject with, and people usually give me a really random look. Lake water, pond water. I've heard Kool-Aid before because it makes your mouth taste like Kool-Aid. But varying on what you use to inject kind of determines what I'm suspecting for what kind of organism we could be dealing with here. A lot of people are using tap water, so that's a lot of your serrations and stuff. So I want to cover against some pretty hardy organisms. I'm generally going to start them on something like vancomycin and cefepime to cover against any kind of environmental organisms they could be using, as well as obviously your common things, MRSA, coagulase negative staph as well.
So, Evan, I want to bring you back in because this patient is sort of a unique guy in the sense that he was discharged with the PICC line and he's an IV drug user. So, you've done a deep dive for us looking at some not only data, but also guidelines on how we can sort of navigate this really delicate balance between trying to treat a patient at home, but a patient who says, oh my gosh, I'm not going to have to do skin popping at all, Sean. I've got an IV line that the doctors just gave me. So Evan, give us some results of what you found.
Yeah, so the one article, one of the main articles where they, I believe it was Tan et al., they looked at about 300 patients in Canada and patients with infective endocarditis and IV drug users. And they looked at their treatments, whether their mortality increased or their bloodstream infection rate increased, whether they were treated outpatient or inpatient. And they actually found similar data between the two cohorts.
So this is interesting actually, because at least the way I read it, unless I'm reading it wrong, I think there were some new isolates, right, when they came back, and sort of indicating that there was some amount of, injection into those lines, right? But it wasn't something that was associated with increased mortality. Is that correct?
Yes, so they did have some patients that were injecting into those lines because you can't be perfect for everything. But I think when looking at their kind of endpoints here of increased bloodstream infections and mortality rates, there was no increase in either of those. So I think it does show possibly some data that you may be able to treat some patients as outpatient with a PICC line who are IV drug users or former IV drug users.
Gotcha. And so how about guidelines for us? Do we have any sort of national body here?
Yeah, so the IDSA gave these not so clear guidelines, kind of suggesting, and they say a case by case basis. And there are some data out there showing different clinician guides that can be used, whether the patient is still using drugs, how many times have they relapsed, have they ever overdosed before? And those are questions that you can use to say, well, they're moderate risk or high risk. But really, it's just kind of dependent on the clinician, whether you feel like taking a risk on a patient or not.
Yeah, and they really gave a lot of room. And I like this about that. And it's not on this thing on the screen here, but you have to sort of go in there. But if you type in drugs, I think is what I typed in. The first time drugs is mentioned is when they sort of get that. If anyone wanted to download that document, or I could send to them. But they actually said something like, we just don't really have recommendations and this can be individualized. So I sort of like the fact that they give us the ability to sort of do that on a patient by patient basis. And of course, this was done way before that JAMA study came out, because JAMA study was 2020 and the IDSA guidelines were 2018. All right. Anybody have, as at the end of our first section, before we find out what happened to the patient, move to our next decision point? Sean, Matt, or Cody, any further thoughts on this? And actually, Cody, I guess I said that you were going to, I was going to see what you thought as far as in the chat. Do you want to read Josh's question and then sort of answer that out loud, I guess?
Yeah, so he asked if we use dalbavancin, which is a long-acting glycopeptide similar to vancomycin, but a single dose at 1,500 milligrams will get you 2 weeks of therapy, which is more than adequate for your most amount of skin soft tissue. You can actually off-label use it for osteomyelitis too, with a second dose a week later of 750 milligrams, get you a full 6 weeks. It's a fantastic antibiotic that I use sparingly, only because I rarely see it inside the hospital setting. When we're able to discharge people with oral antibiotics after a day or two, it's pretty easy to do. There are a few people where the cellulitis is just unrelenting. I've got you on day 3 of cefepime and Vanco, and it's barely getting better. And then day 5, 6 turns a corner. Those are people that sometimes I don't like to get out with just oral antibiotics because it took so long with just IV. So dalbavancin is a great option there. And I think it is a good option for the ED to start using at some points to kind of prevent some of these admission people to just cover broadly against cellulitis, covering organs and skin, soft tissues. It is very good, but getting it onto formulary, making sure that it's approved with the people's insurance is an issue, because I've had to talk with case management a lot and run it through the pharmaceutical company. So it is kind of a pain to do, but it is a very good antibiotic to use.
It's not on the $4 generic list yet?
It is not.
I just looked it up, Mike. I think it's 6,500.
Okay. Yeah, $4 times a lot. Times something, right? Times 1,500. All right. So what happens with our patient? So the actual provider said plan for an EKG, chest x-ray, basic labs, cultures, lactate, sepsis workup. The patient's tachycardic will give IV fluids, and they looked at the previous record, showed bacteremia with MSSA, and an echo, which was negative, but a CTA concerning for septic embolia. As we sort of know, the patient's been on nafcillin since the discharge. So chest x-ray is done, shows a left pleural effusion, left mid and lower lung airspace disease increased since the prior study. And they, as a radiologist can sometimes do, which is cool because they're not seeing the patient, it could be symmetric pulmonary edema or pneumonia. Also, a lot of choices. So let's move to our next decision point. And I just sort of wanted to start off with Evan here, obviously with your pulmonary and acute care interest and expertise, right? We have an effusion and possibly a pneumonia at the same time. What is the difference in just a regular pneumonia from a pneumonic or some sort of loculated type of effusion?
Yeah, well, most pneumonias, especially inpatient, I believe it's about 20%, you will see a parapneumonic effusion. And whether it's uncomplicated, complicated, or an empyema is where you have to make that differentiation. So uncomplicated is that sterile, free-flowing exudative effusion. Sterile meaning it's not going to grow any organism on your culture or grain stain. Your complicated parapneumonic is where you have possibly some loculations. You have that low pH, less than 7.2, low glucose, and then usually, almost always, you will grow an organism on your gram stain or culture. And then empyema is really the presence of pus, if you have pus on that tap.
So Sean, I'm going to ask this question, then Cody, if you want to weigh in on that also. When I was in training, they had this expression, the sun never sets on a pneumonic effusion. And I know that things are a little bit different, like the whole, attention pneumothorax on chest x-rays and mark of shame on the clinician who ordered it, right? Well, that was when you went back and developed the film and popped it up, and it was like half an hour later and it's wet and dripping like whatever weird chemicals on you that used to be on those old x-ray films that they saw on TV shows, right? And now it's like you take an x-ray in the room, right? And you see the image immediately. So as far as attention pneumothorax, of course, it's not really still true for that. But what is the timeliness, Sean, and then Cody, if you want to weigh in on treating or draining a loculated effusion?
Well, I mean, this guy's getting sicker, but he's getting sicker over days, right? Really not hours, right? So, and you have to put yourself, now I have no idea where they're practicing, but I practice in 2 level 1 trauma centers. One's got 120 beds, the other one's got 90 beds. I'm getting, we call it a MICU consult, right? So I'm consulting the ICU on this guy, right? I'm worried about him. I'm going to make sure we're all on the same page, but I'm probably not going to do anything other than to speak to my resident and say, hey, if he goes south real quick, this is what we're doing, right? So I think just the way I always think is like, hey, what can happen and what am I going to do if it's happening, right? So I always want to make sure everybody's cool, but am I sticking a needle in this thing? No, not even under, I'll guide this, right? Because I don't think I need to, right? I mean, I'm going to have him in a room on a monitor. I'm going to walk by as often as I can, which I usually do. I don't like curtains closed and doors closed, right? So I'm going to keep an eye on this guy, but I don't think, and again, that original paper where this is from, I mean, it's several decades old, I think, at least, so, but again, I mean, I'm never point fingers because like just practice changes, right? But we can get things a lot quicker now. And I think the expectation is if he's not crumping and I drop his lung, right, and I have IR that's relatively immediate, relatively available, like what did I really do? You know what I mean? So I'm not looking to complicate this guy's life more than it's already complicated. That being said, don't blow this off either, right? Like he's evolving. He's evolving over days, and I'm assuming that's why he wound up in your book, like that. This is kind of, the slow drip, drip, drip of this guy bouncing back. As much as LeBron bounces basketball, this guy's bouncing back to the ED. But it's just interesting. But I'll hand it over to Cody. But just to answer your question, I do not agree that the sun can go down occasionally on these.
Do you agree, Cody?
I agree. I wouldn't be sticking a needle in this right away. I do want to see if it's growing anything. I do want to see what the cell count, glucose, pH are. I'm going to give antibiotics in the meantime while I wait and the sun goes down in this pneumonic, but I wouldn't be sticking a needle in it right away either.
Okay, gotcha. Do you feel that when you're considering that the antibiotic selection should be any different or still what we talked about before? I think you had mentioned, Vanc, cefepime, that'd be a pretty adequate place to start until we sort of have cultures to guide things and narrow them down a little bit.
Yeah, I think it's adequate. This is the one where he had MSSA, and we already knew at that point got discharged on Nafcil, and now he'd been in here several times. Could he have picked up a MRSA pneumonia at that time? I was taught in fellowship you can be recolonized in MRSA in 5 days. So did this guy have MSSA initially? Now it's MRSA. He was discharged with a PIC. Now does he have Pseudomonas in the lungs because he's injected? Now he's bacteremic with that. There's a lot of things it could be. So it's not wrong to anchor and just say, all right, we're going to keep on the same antibiotic we discharged him with. But for this person, I would probably expand it till I get blood cultures, until I get the fluid, the pleural fluid back. I would cover with probably something like then vancomycin for MRSA, and the cefepime. You wouldn't want to do 2 beta-lactams with the cefazolin or the Nafcillin that he was on, and something like cefepime or ceftriaxone either. So to avoid that, I would probably do the vanc and cefepime combination here.
Okay, awesome. So, Matt, I have had so many cases, as I'm sure you have also, where the chest x-ray is normal or shows something minimal, and you do a CT, and it's like, oh my gosh, how was that not seen on the chest x-ray? And we're always trying to balance, right? The risk of missing serious disease versus the risk of harm from extraneous testing and radiation and expense and all those types of things, right? But I'm just curious, first of all, in general, and then specifically for this case, are you good with the chest x-ray, or are you ordering more advanced imaging in this specific situation? And if you do go for a chest CT, are you doing a non-con or a chest CT with contrast?
Yeah, all of the above. So I think if I'm looking at a patient saying, can I tell if there's an effusion based on a chest x-ray? I think yes. I think the literature says, yeah, the big ones that would cause trouble, we can see on a chest x-ray. But I think to take a step back, if I've got a patient that's got risk factors for infection, I've got an underwhelming chest x-ray, and I kind of tie it to I'm doing my sepsis stuff, my fluids, my antibiotics, and he's not getting better, whether that's some physiologic parameter, whether he's got a lactate that's going up. I'm going to call the ICU like Sean was talking about, but that's the patient I would think about scanning. And I would actually broaden it out a little and say, you act septic, you're a risky dude. I'm going to scan chest, abdomen, pelvis with contrast, not in all my septic patients, but in the one that doesn't fit the pattern. We're good at sepsis, and we rarely get off track with sepsis, but when we do, I think that's where a CT is helpful, not to confirm when I see an x-ray, but just to look, because you're right, you see pneumonias you might not have seen, you see abscesses. I've seen effusions this way. So in isolation, I'm good with chest x-ray, especially because we're not really worried about the sun setting anymore. But I think when you're worried about a septic patient, you're not winning the battle. I've got a lower threshold to image those patients.
Would you then do like a CTA as your contrast, or just a regular chest with contrast? Because I mean, probably this guy doesn't have a PE, right? And I know that you're then extending that to the abdomen and pelvis too, but sometimes it seems like there's not really a lot of downside risk to doing it as a CTA. Do you ever do it that way, or do you just get the chest CT with contrast?
It depends on who's reading the films. My preference is that I get a CTA because I get the arterial phase and the venous phase, right? So I'm getting just a normal contrasted study plus the arterial phase. In my hands at my shop, it's 50-50. A lot of times I'll be told by the radiologist, hey, just get the contrast with that venous phase. We can see what we need to see. But yeah, if you let me run the world, I'd get CTAs on most of these patients just for that extra piece of data.
Yeah, and it's going to be sort of like that thing where you scan a, ROSC patient after, return of spontaneous circulation, that a lot of times you find stuff on that head CT, and I think we sort of for a while turned the wheel too far against that radiation. And man, we had this amazing test, the CT scan, and that oftentimes we find all kinds of stuff when we do that. And what you said I wanted to really focus in on is this is a risky dude. This is his fourth visit in what, about a month or a little bit more, right? Or a little bit less, whatever it was. And, he's already on antibiotics and good antibiotics, and still something's happening, right? So certainly getting further information certainly could be the thing that saves his life. My guess is this guy here at the age of 35 with diabetes and IV drug use is probably not going to die from a radiation-induced cancer.
Yeah, the stats are not in his favor that that's going to be the thing that gets him, unfortunately.
Right. Yeah, exactly. All right. So, other comments at the end of decision point B before we find out what the actual clinician did and move on to our last set of decision points? All right. And, I just want to also say there's a lot of expertise of, participants, folks that are on this call too. So certainly putting stuff on the chat and, weighing in, love to hear from you. And we'll certainly address all comments with stuff too. All right. So here's what happens. So, medical decision-making note, the patient meets SIRS criteria. Lactate and blood cultures are drawn, additional in labs, IV fluids, consulted ID, and the radiology report was reviewed from the past, but they did note a left-sided loculated effusion. White count 13.5, basically not helpful. A little bit of hyponatremia, not that big a deal. Lactate is 2.2, and on repeat vital signs, now the guy is still pretty tachycardic. I think he was, 131, now he's 128, so basically almost identical, but he's tachypnic, a little bit hypotensive, and now on 6 liters, he's only 91%. So let's move on to our next decision point. And Matt, why don't we just stay with you here? Just to recap, 6 liters, 91% sat. Where are you going next, oxygenation wise?
He needs one of two things. He needs his FiO2 bumped up or he needs PEEP. And so I make it simple. If you're on oxygen and you're below 95%, what I'm going to do is I'm going to put you in a non-rebreather. I'm going to crank it up and keep turning on the wall till you get that kind of 20 to 40 liters per minute. And that way I can look. And if that fixes you, I know it's just an FiO2 problem, which is the minority of the patients we see. But if I put you on more oxygen, you're still hypoxic. And I would say below 95 is enough for me. You need some PEEP. You've got stuff in your lungs. You've got shunt physiology. We've got to move that crap out of the way. So I have a low threshold in this patient where I just need to make functional lung space. I'll hit you with some BiPAP. I can de-escalate. If I overreact, we can take that off. It's not a huge deal. But yeah, very low threshold in this patient to give him some positive pressure, see if that helps him.
Yeah, no, we all get busy with other patients and, their squads are coming in and there's assigning you all these other patients. But this guy, arguably is going down pretty quick. Probably one of the sicker people who's still alive anyway, who has a chance in the department. So really making sure there's, face-to-face communication with the nurse, frequent rechecks of this patient. It sounds like you're actually doing that right at the bedside with this patient. So absolutely giving this guy extra TLC is super important. So Sean, you mentioned one of the substances, patients who use intravenous drugs and substances. Cody mentioned the phrase lick and stick, right? So certainly things, but there's other things that can be mixed into substances that are injected, as well as other things that we need to think about in injection drug users.
Yeah, so I'll keep it because there's actually quite a lot. So Cody said it exactly right. People go in the toilet, they use toilet water, right? They can use all this kind of stuff because the way, and I think most people know how they do it, but it's really not heroin anymore. It's really fentanyl. It's very unlikely, although we still see some black tar, but not nearly as much. But a lot of that just for one reason or another can have for lack of a word, soil, feces, right? Animal manure, right? Particularly the black tar is quite well known for that. Cotton fever that I just haven't seen in a long time, but if people will draw this up because they don't want to get particulate matter and cause like a phlebitis. So they'll suck it through cotton, they get those cotton fibers, talc. So heroin nephropathy often was thought to be from the other substances like talc and other things, actually not from the heroin itself, because you don't see nephropathy from morphine. And I remind everybody, the real name of heroin is diacetylmorphine, right? So it's more likely not than not. IVDU, because we're not just talking about opioids. So cocaine has a fair amount of it has levamisole in it, which can cause a vasculitis that, and then xylazine, right? We're seeing quite a bit now. If you've heard of tranq, which is what they're calling it because it's used in veterinary medicine. So you can see like an opioid-like syndrome, but a lot of these things are not what we'd say pharmaceutical grade, right? So someone could get powdered xylazine, let's say, and just kind of make it into solution. So you can get all the problems you can with not having sterile injectable stuff. So, but those are probably the most common things that I would think. Otherwise, I could keep you on for an hour, Mike. You don't want that.
Exactly. All right, Evan Price. We're obviously watching this pulse ox going down. Now it's 91% on 6 liters. How frequently would capnography actually change your management beyond just using pulse ox alone?
Well, I would say probably not too much. We don't use it a ton at our hospital outside of the ICU intubated patients and outside of CPR. So really the data has not been shown to change much on the hospitalized patient, although there is an inverse relationship between capnography, so low EtCO2 and high lactate levels. So if you were maybe concerned that somebody is getting worse septic wise, that's where I could see it be used. But you're still going to do your basic care on somebody, not use capnography.
Okay. So thank you very much for that. Cody, do me a favor, we got this guy, there's obviously a lot of possibilities. We've done some pretty good amount of testing. I don't want to ask you the same question just as far as the antibiotics, because we sort of have them on this initial dose and we're just sort of waiting for culture results to come back. But let me extend as far as testing goes. Would there be additional type of testing with this specific patient who comes in already on antibiotics, as far as any serum, urine, sputum, antigen type testing, or something we could find with a bronch, or maybe something even based on interventional radiology going into if this was a loculated effusion empyema? What are some next level types of diagnostics that we could do infectious disease wise on this guy?
Certainly starting from a sputum culture. If he's got a loculated effusion, he's coughing stuff up, the most fastest way to get anything is going to be your just coughing up whatever you're coughing up into a cup and sending it down. And we can do a gram stain. That's fairly helpful sometimes. Obviously, bronchoscopies can be better, but we've got to arrange the anesthesia. That's usually a next day process. With this person who probably has some risk factors for tuberculosis, history of IV drug use, maybe there's homeless shelters, maybe some incarcerations, that kind of stuff falls around the same crowd a lot of times. You got to be worried about pleural-based tuberculosis, so sending them for adenosine deaminase from the pleural fluid would be pretty helpful to determine if it is tuberculosis. The pH, obviously, less than 7.2, and the glucose less than 6 would be indicative of some kind of a infectious process going on in there. Obviously, a gram stain if it's pus. Not so much fungal here for loculated pleural effusion in this person. It's possible, but it would be probably the lowest list here. I wouldn't be too worried about like a PCP pneumonia again with this loculation pleural effusion. There's nothing. Seems like it's more of like a multifocal pneumonia with these PCP people, but start with the sputum culture, move for a bronch, and then if we can get that pleural fluid out, send for those other sample studies, I think that'd be pretty helpful.
Okay, gotcha. So we're going to find out what happens with the patient. We're going to wrap things up with the QR code, and then each of us will have 30 or 60 seconds to sort of bring home some big teaching points here. So the patient was placed on BiPAP, SAT increased to an adequate amount, and his respiratory rate improved also. Cardiothoracic surgery with the empyema, and they did on CT scan find a new small to moderate loculated left pleural effusion with some foci of gas consistent with an empyema, as well as some bilateral septic emboli, but those had decreased in size with the NAF cylinder for whatever reason that they decreased in size. Admitted to the hospitalist service based on his improved hemodynamics. CT surgery decided not to take him emergently to the OR, but to wait on that. And he was diagnosed with empyema, sepsis, and IV drug use. During the hospital course, he did eventually go to the OR. He got a left thoracostomy and decortication, spent several more days there, and was discharged with continued IV antibiotics. So this is an interesting case to me, not only because of the multiple bounce backs, which maybe could have been predicted, and maybe is not even that surprising because you have a guy who has a history of IV drug use who you put a PICC line into, right? And so I'm sure that that part was focused on also, but certainly this guy being that sick probably wasn't the time that he super motivated to stop using IV drugs. So certainly that'd be a pretty significant risk going forward with that also. So what I want to do is just put the QR code up for folks to get CME credit. You can shine your phones on that if anybody wants to weigh in on the chat. But I was going to go just through each of us, and then I can sort of round things out with some teaching points. So Matt, and I failed to mention at the beginning, but this is your chapter in the Bouncebacks Critical Care book. So this was a chapter you know and knew and loved, and put a lot of TLC into it, and it turned out great, by the way. But anyways, Matt, what are some things that you want folks to take home after this hour tonight on Monday night?
Yeah, this is a lesson to myself in the middle of a bunch of night shifts, is that patients in the midst of addiction can be very difficult patients. And I think one thing that broke correctly or went well in this case is the guy kept coming back to the hospital. And so I would give kudos to the teams that took care of him. I know how hard these patients are. Addiction's a monster, but do what we can so that these folks, when they get sicker, come back, because I think we've all seen the alternative, which is they end up dead in a park. And so I think this is a great reminder that this is a fatal disease, and that we got to dial up the empathy a little bit so that we can try to get them in a better spot. That is stunning that this guy came back this many times and allowed them to treat him. So good on the team. They didn't nail it the first time, but I think they did a lot of stuff right.
I've seen so many times, Matt, where IV drug users are like, they didn't treat with respect, and they leave, against medical advice. But this guy was, it seemed like, treated well, and then chose to come back because obviously he felt like he was welcome to do that. So you're right, kudos for that. How about let's see what order we have for our final comments here. Evan, why don't you go next with some things you'd like folks to take away, or maybe even something that you'd use to change your own practice based on our discussion here tonight?
Yeah, I think something that Dr. DeLaney said previously is, and that I've used before, is that if the picture's not fitting, then look for something else going on, and don't be afraid to just keep looking, and don't just say, oh, it's probably this. So that's one big thing. And then something I always say to myself on internal medicine or in the ICU treating somebody is, did I do everything that I can safely discharge this patient to a different floor with the best standard of care? Did I do everything I could in my book? So those would kind of be the two big things.
Awesome. Thank you so much. And Matt, congratulations that Evan chose to quote you instead of Cody or Sean. So sorry, guys, but
it's a youthful mistake. I'm the wrong guy to quote.
All right, Cody, what would you like folks to take away from this time tonight?
I think this is a good case, and it can happen in any clinical situation, IV drug use or whatnot. I have a lady on my service currently actually who's strep pneumobacteremia. I've seen so many post-COVID or post-flu pneumonias this year. And she was one bacteremia and still on nasal cannula day 3, day 4 on good antibiotics and looking well. So something didn't sit right. I got a CT scan. It showed a large loculated pleural effusion. Same thing. She got a decortication. Had a right lower lobectomy, discharge planning tomorrow, I think. She's doing well, but it just didn't fit. I like to tell the patients, families, when things aren't working really quickly that, these things are not magic bullets. Antibiotics don't work like instantly. Even if you're on the right antibiotic, it might take time. It might not still work. This person was on Nafcillin for MSSA. Great antibiotic, works for it. This lady that I'm speaking of, ceftriaxone for strep pneumonia. We know it works, but sometimes we have these clinical situations where things just don't add up. So we have to kind of look a little, flip over every rock for this.
All right, Sean, the last word.
All right. Well, I'm gonna quote everybody. Hey, great job presenting, Evan. So a couple of things, but I'm just reiterating what people have said. So number one, I would have done a CTPA and I would have done exactly what Matt said. Like I would have said, like, hey, and I would have told the patient, like, I'm not sure, right? But I gotta look, right? Because those vitals, the first vitals and second vitals bug me. They just do, whether I saw him like in real time or now. The other thing is, yeah, when you hear IVDU, like always believe your patients. It's a slippery slope when you don't. If they say they're a former user, but just consider that they might have had a slip, they might have and just include anything you would in an active user. And then what Cody said is, and look, antibiotic stewardship is very important. Don't be treating viral syndromes with a Z-Pack. That being said, start very broad, like he recommended. This person, if you did very narrow coverage and said, well, I think it's endocarditis and I'm just going to put them on Vanco, or you're going to potentially miss something. That's what the cultures are for. That's what, and so they can always revise it upstairs. Start broad and just let it do, but just don't do it on everybody, right? So I think that this is a really interesting case. I think it was a tough case, but I think if there was a little bit more aggressiveness up front. I don't think anyone did any wrong, but I think that the slowness to the ultimate was just because maybe a little bit more aggressive up front. But thanks for having me, Mike, as always.
Well, thank you so much to our panel, and thanks to the folks who've taken the time out tonight away from your family and your lives, right, to spend this time. I hope we were true to this hour. To register for future book clubs, as well as see this video for folks who feel might benefit from it, and previous book clubs, go to the EM, like emergency medicine, bouncebacks.com. This is the QR code for our book club on April 1st. Is a 50-year-old woman with flank pain and ureteral stone. What could possibly be wrong? Case number 21. So thank you so much to everyone again, and have a good rest of your night. And Matt DeLaney, who is in the midst of 9 night shifts in a row, good luck to you mostly, my friend.
Thanks, guys.
Bye, everybody. Thanks again.
Thanks, guys.